Phenibut is a derivative of the inhibitory neurotransmitter GABA. It has been widely used for medical purposes in Russia and former Soviet countries, whereas it's a non-prescription and unapproved, though legal, drug in most other regions. It has stress-reducing, anxiolytic, and sedative effects. At common doses, it's often easier to be alert and functional relative to other GABAergic substances, like benzodiazepines. Because it's sold as a supplement, many people use the drug under the false assumption that little care is required. This is not the case. It should be treated like other GABAergic substances, recognizing significant impairment and sedation can occur with overdose, as well as that physical dependence is a significant risk with daily or near-daily use. Physical dependence is one of the major downsides of the substance, as both tolerance and withdrawal can appear within weeks of beginning daily use, depending on the dose. If you want to learn more about the drug or view my references for this information, head over to the corresponding TDC website page using the link in the description. As with any drug, the most I can do is provide an outline of the typical effects. Your experience is not going to perfectly match the description I provide, since there are different ways people can respond to a drug. It's primarily used in Russia and former Soviet regions, such as Latvia. It's not approved in the EU, US, Canada, or Australia. It's also difficult to see many conditions for which it would be the ideal prescription drug. Some of the Russian literature has described such a wide array of uses that it practically seems like a wonder drug, but many of its effects have not been sufficiently validated. Some of the common applications are for psychological and cognitive conditions characterized by hyperactivation, such as anxiety, certain elements of schizophrenia, stuttering, tics, and hyperactivity in children. Because so much of this overview relies on the Russian literature, and sometimes only abstracts from that literature, Phenibut's efficacy in any condition should be viewed with skepticism. I would like to see much more validation from separate research teams, especially with long-term use, before considering it a good treatment. It appears to be used in Russia for ADHD. Studies have shown a decline in core ADHD symptoms and an improvement in cognition, specifically with memory and attention. It was also shown to normalize electrical activity in ADHD patients. A couple studies have reported efficacy in anxiety and panic, where it can address core anxious symptoms and improve cognition. Globally, this is one of the most common uses of the drug. In Latvia, it is sold with the acetylcholinesterase inhibitor apitegrine under the name Cognifen, which contains 300 mg of Phenibut and 5 mg of apitegrine. This combination has reportedly improved cognition in people with vascular disorders, but the role of Phenibut in that efficacy is unclear, given apitegrine is a significant confounding factor. Animal research has given mixed results on its cognitive effects. When taken at 250 mg 3 times per day, 2 studies from the same group reported efficacy in tension headaches. However, in people not already experiencing headaches, Phenibut is widely reported to be a trigger of head pressure and headache depending on the dose. Phenibut has protective effects in neurotoxic and/or cognition-impairing insults like electroshock, scopolamine, and hypoxia ischemia. Both GABA-B agonism and calcium channel antagonism may be protective in ischemia. Applied to humans, this could potentially make it helpful during and after cardiac disorders like stroke. Other GABAergics seem to be better seizure medications, since it's reportedly less effective than diazepam, despite working in some models, such as seizures induced by kynurenine. GABA-B receptors are a potential target for reducing pain, and one study in women with chronic neck pain found it was effective. It's been reported to reduce stuttering, tics, and asthenia characterized by weakness and fatigue in children and adolescents. There are at least a couple distinct ways to use it. On the one hand is therapeutic use for anxiety and stress, typically at 250 to 1500 milligrams, and on the other is overtly recreational, usually at 1500 milligrams or more, sometimes up to a few grams. On the lower end of the range, the drug is active, but unless it's addressing stress or anxiety, it may be pretty subtle. When people aren't just looking to make their day a little better, that's when the dose increases. But the concurrent rise in side effects, after effects, and impairment must be kept in mind. Phenibut's activity is dose-dependent, though it's a bit unpredictable between users and to a lesser extent between uses by the same person. So while it is accurate to say the effects increase the more you take, 750 to 1000 milligrams will be powerful and adequate for some, while others report needing 2 to 3 grams for equivalent effects. It's common to find the drug works best in a narrow dose range, with too little not doing enough and slightly too much being prone to causing hangover, headache, nausea, and oversedation. However, the narrowness being described here is usually still a range of at least 300 to 500 milligrams, and that only seems like a narrow range when people are viewing Phenibut as a drug that can be taken at anywhere from 250 to 3000 milligrams, rather than treating it the way it's been used in medical settings, where the dose is around 250 milligrams up to a few times per day. Creating an overview of the effects is complicated by the wide range of doses people use and by there being different responses to the drug. Some people absolutely love it. It brightens their day, is good for socializing, isn't very sedating, and it's either free of after effects or provides an afterglow the next day. For others, it has a mix of positive and negative elements in that it's effective for sleep and anxiety, but it's not very euphoric and it may come with a hangover. And yet others mostly don't respond well to Phenibut, reporting it's ineffective or that any dose makes them nauseous, hungover, unproductive, and generally unpleasant. Overall, the majority of users can at least get anxiety and stress reduction, but the rest of its profile is a bit more variable. Impacts on mood, motivation, and how you feel the next day will differ a lot. Like with benzodiazepines, reports of common doses yielding strong mood enhancement and subjectively life-altering effects may be most common among those with pre-existing stress and anxiety that would usually hold them back. Going hand in hand with this property, the anti-stress and anxiolytic effects will be most obvious in stressful situations, going so far as to only be good in stressful situations for some people. There's also a biphasic aspect to its effects that many users report. Somewhere around 4 to 6 hours after administration, the effects change. It appears the first few hours involve a gradual onset of relatively weak and potentially benzodiazepine-like minor sedation and relaxation, but within a few hours later, the full effects really come through. Those include a rise in sociability and a stronger uplifted feel, though this is also when many people report it becomes easiest to sleep. Some common, though unconfirmed, suggestions for enhancing Phenibut are to combine it with coffee and/or physical activity, and to take it on an empty stomach. Enough people have reported beneficial effects from these factors that there is probably some truth to it working well with exercise, perhaps working a bit faster with coffee, and being most noticeable when you're not eating. With physical activity, people often say it speeds up the onset and generally improves the effects, increasing the chance of it being enjoyable rather than producing a bored, drowsy, and disinterested feeling. It may be less drowsy and more mood-altering than baclofen. It's usually said to be weaker at common doses than pregabalin and gabapentin, producing a less altered feeling. It's less cognitively impairing and usually cleaner overall with its effects than alcohol. And it's comparable to benzodiazepines for anxiety reduction, but otherwise it differs by being more energetic, more pro-social, and not having a generalized emotional blunting effect that's often reported with benzodiazepines. The typical response to Phenibut is to feel less stressed, more social, and less anxious, perhaps while having a mood-brightening effect and a sense of well-being. The effects are not strong enough at low to common doses to be very impairing, though driving should be avoided. At low to common doses, it's not strong with its altered effect, so some users describe it as feeling similar to themselves on a good day, or themselves but better. Some level of mood enhancement is typical, and while substantial euphoria might be more common than with benzodiazepines, it's still not a typical effect at any normal dose, as opposed to simply having a brighter, happier day. Sometimes users will experience periods of euphoria early in their use from higher doses, and proceed to chase that effect in subsequent chronic use, which is not a good idea. It has a general anxiolytic effect and is particularly helpful with social anxiety and other forms of social-related stress, such as performance anxiety. Along with tamping down anxious thoughts and sensations, it may promote more open communication, and it doesn't seem to blunt emotions like benzodiazepines can. Because of its disinhibitory effect, users can become a bit more animated in conversation and more likely to try new things, especially things they've been avoiding because of anxiety, because it tends to enhance confidence and people's desire for social interaction, while doing so in a cleaner way than higher doses of alcohol. People find it can work well during presentations, interviews, or social events. The disinhibition can become a negative when high doses are taken due to making risky or regrettable decisions, as is the case for most GABAergics. Lower doses around 0.5 to 1 gram most often have a neutral or stimulating effect on energy. This energetic effect is observed even with higher doses of 1.5 to 2 plus grams, but it's less reliable. The impact on energy can contribute to sociability and productivity, though with a variable effect on those two areas of functioning, since some users find themselves in a pleasant yet unproductive mood. So it's fair to say pro-social effects are more reliable than pro-work effects. It's been somewhat misleadingly labeled a nootropic. While it may support cognition by alleviating stress-induced declines in cognition, or by generally assisting with focus and alertness at lower doses, the overall effect of the drug is not that of a pure cognitive enhancer. It appears, however, to at least preserve cognition better than benzodiazepines or alcohol, and this contributes to it feeling much more clear-headed. A minority of users experience enough impairment in the form of spaciness and reduced focus or attention at lower doses of under 1 gram to make it unsuitable for use during work. Sleep is usually enhanced, reducing sleep onset latency and increasing sleep efficiency, partly because of its long duration. The long duration can also lead to people sleeping longer than usual if an alarm isn't used. So long as low, common doses are taken, people usually feel normal or better than normal the subsequent day. The sleep it produces is frequently described as deep, but exactly how it affects sleep architecture is unknown. Regardless, it is predominantly positive for people with and without insomnia, but outlier reports do exist, such as people finding it difficult to sleep more often during the first half of the effect period, or simply not noticing an effect. Grogginess or an unproductive mood for the first part of the next day are possible. Libido often increases, sometimes very substantially, in a dose-dependent way. It's not a major effect at low doses. Music enhancement of varying degrees has been reported, allowing music to sound better and for listening to be more immersive than usual. Nausea and vomiting are common effects and become more likely the more you use, causing stomach pain and general GI discomfort. Strong doses can impair your motor skills, leading to less coordinated actions. Some of the physical effects are pleasurable, such as a body high featuring sensations of warmth, and it usually has some muscle relaxing properties, yet it can produce paradoxical muscle twitches with higher amounts. Headache or increased head pressure are common with strong doses, but severe headaches are not typical, despite having occurred for some. Other physical effects include ringing or buzzing in your ears, slurring of words with high doses, increased urination, cold sweats, and delayed ejaculation, though not coupled with reduced pleasure. It has a minimal impact on perception at common doses, but it can cause dose-dependent vision impairment with higher amounts. The most noticeable effects include strong doses causing some blurriness and lagging. In other words, taking longer to start focusing on a new object. Like other gabapentinoids, it can produce a range of subtle changes in the texture of surfaces, usually at strong doses, though these may not be very noticeable until you're paying attention. There are a few reports of it aggravating visual snow, though it's not clear if that's common, given the lack of reports specifically discussing it. The after effects are highly dependent on dose and timing. Taking a strong dose, particularly in the afternoon or evening, can easily lead to effects the next day, and those may not be positive. Some people receive an uplifted mood the next morning, essentially continuing a weaker version of the positives from the prior day, but others are groggy and unproductive. Rebound effects usually only kick in after using for at least a few days, so it's not common to be depressed or anxious from a single use. It's pretty common to have a mixture of positives and negatives, such as being relaxed or mellow, but not very productive for at least part of the day. It is frequently said to improve the effects of stimulants, psychedelics, and perhaps entactogens. For stimulants, it can reduce jitteriness, uncomfortable physical stimulation, and anxiety, while preserving or enhancing the mood effects. Usually, people report this makes the experience feel smoother, and the two drugs may also yield a preferable energetic state and greater effects on socialization and libido than either alone. Come downs, such as sleep trouble and low mood, may be somewhat alleviated. For psychedelics, it can also make the body load easier to deal with, and it can notably reduce the chance of a very stressful, confusing, or anxious experience. Bad trips often begin with a minor negative thought or a bit of confusion, spiraling out of control, and it seems Phenibut can reduce the chance of this happening, so long as the dose is kept relatively low, like 250 to 750 milligrams, it may cause little degradation of the visual effects. Like with the stimulant combination, Phenibut may make the come down smoother and sleep easier. Combining it with alcohol is not a great idea, although it can be done safely and should not be physically dangerous when a common Phenibut dose is combined with 1 to 3 drinks. It does significantly raise the risk of oversedation, general drunkenness, and hangover. If enough is taken of either drug, the combination can be physically dangerous, coming with risks like severe impairment, coma, respiratory depression, and vomit aspiration. So while they may work together well to improve mood and socialization, if taken carefully, the risks associated with the combination make it worth avoiding. Phenibut is a derivative of gamma-aminobutyric acid, commonly known as GABA, that includes a phenyl ring bonded to GABA's beta carbon. Structurally, it is similar to baclofen, differing only by the absence of a chlorine atom. Despite being similar to baclofen, Phenibut is much less potent as a GABA-B agonist. Its R enantiomer is more active than the S enantiomer. Most reports of Phenibut's effects come from people using the HCl salt, but the free amino acid version does exist. Some people prefer it due to swallowing the powder or using it sublingually and buccally being more pleasant because of the lower acidity. Although sublingual administration is still fairly impractical due to the large amount of powder. It's also more potent by weight, so the oral dose is lower. Reports vary as to any other differences. For some, it's less likely to cause stomach discomfort, but usually the rest of the core psychological and physical effects are essentially the same. Until the 2010s, Phenibut was best understood as a GABA-B agonist, like baclofen, but more recent studies have shown additional activity as a gabapentin or pregabalin-like antagonist of voltage-dependent calcium channels, containing the alpha-2 delta subunit. Phenibut also has a higher affinity for this site compared to GABA-B, so it can be viewed as a major contributor to its effects. Those two mechanisms, GABA-B agonism and alpha-2 delta subunit antagonism, cause downstream effects leading primarily to reduced neuronal excitability, which depresses various kinds of activity in the nervous system. A combination of those mechanisms likely yields the core effects of anxiolysis, sedation, and sleep induction or enhancement. Complete knowledge of its pharmacology is limited by a lack of detailed, accessible, and trustworthy research. It has never been widely studied outside of Russia and a few nearby countries, so the majority of published information about its effects can only be learned about from summaries rather than from the full texts of the studies. However, full studies are available supporting its GABA-B agonism and calcium channel blocking effects, so those aspects of the drug can be considered fairly reliable and well supported. GABA-B receptors are G-protein coupled receptors, GPCRs, that exist in presynaptic and postsynaptic regions to modulate neurotransmission. They were originally identified as distinct from GABA-A due to being a lower affinity target for for GABA and being insensitive to the activity of the GABA-A antagonist, bicucholine. Early research showed Phenibut interacted with the bicucholine-insensitive receptors. The receptors have a core domain of 7 transmembrane helices, and they are heterodimers, meaning each receptor complex is made of 2 subunits, GABA-B1 and GABA-B2. GABA-B1's extracellular domain binds GABA and other ligands, like Phenibut, while the GABA-B2 subunit couples the receptor with the effector G protein. Functional receptors require both subunits. This receptor is distributed throughout the central and peripheral nervous systems, with the highest density in the cerebral cortex, thalamus, cerebellum, and amygdala. It is primarily coupled to G-alpha-I proteins, and via its action on G-alpha-I and the G-beta-gamma complex, it causes an inhibitory effect in neurons via the inhibition of presynaptic calcium channels, activation of postsynaptic potassium channels, and inhibition of adenylocyclase, the enzyme that causes the transformation of ATP to cyclic AMP, an important second messenger. Presynaptically, it mostly inhibits N-type or P/Q-type calcium channels, reducing neurotransmitter release. Postsynaptically, there are interactions with potassium channels, especially inward rectifying channels, causing hyperpolarization. Agonism at this site is more often linked with cognitive impairment in animals rather than cognitive enhancement. This even led to the development of a GABA-B antagonist, SGS-742, that was researched for mild cognitive impairment. Detailed research into Phenibut's cognitive effects in humans does not exist. When animals lack functional GABA-B receptors, they are more anxious, though some studies report antidepressant effects when GABA-B is absent, despite Phenibut often being taken by humans to improve mood, and despite Phenibut having antidepressant-like effects in animals that are blocked by GABA-B antagonism. Clinically, GABA-B receptors have been implicated in pain, seizures, and motor disorders. If you knock out functional GABA-B receptors in animals, they show spontaneous seizures, premature death, decreased pain threshold, and cognitive deficits. Although GABA-B activity is protective against some forms of seizure, it seems involved in the generation of absent seizures, so people with that condition could experience an exacerbation from Phenibut. Tentative results linking GABA-B abnormalities to autism, bipolar disorder, depression, and schizophrenia also exist. If any of these connections hold true, they could help explain part of the social and mood benefits associated with Phenibut. The prototypical gabapentinoids, pregabalin and gabapentin, block the alpha-2 delta subunit of voltage-dependent calcium channels, and that mechanism is now known to constitute a fair portion of Phenibut's pharmacology. Research in the 2010s demonstrated it competes with gabapentin for its binding site, has a higher affinity for alpha-2 delta than for GABA-B, and it has some gabapentinoid-like effects on pain. Blocking this site, which reduces the influx of calcium ions, can reduce the release of excitatory neurotransmitters like glutamate. Phenibut may or may not affect glutamate decarboxylase and/or GABA transaminase, but an increase in the concentration of GABA has been reported. In vitro, Phenibut increases calcium-dependent spontaneous release of GABA, and it causes an increase in GABA in rat striatum. Phenibut and GHB may have an inhibitory effect on GABA transaminase, and if true, and without a co-occurring decline in GABA synthesis, this could contribute to higher GABA levels. It is frequently claimed to boost dopamine activity, but little evidence exists for that effect. Research has shown it may affect dopamine metabolism, though not in a way that reliably produces higher dopamine levels. Rather, it may increase the speed of synthesis and catabolism. When that effect is combined with its general inhibitory effect on neurons, a reduction in dopaminergic activity could exist, with potential variation between brain regions. One study reported it antagonized dopaminergic drugs and potentiated the cataleptic effect of the dopamine antagonist haloperidol. Another found spontaneous release of dopamine was not altered in the rat nucleus accumbens at 50 micromolar, but Phenibut did reduce potassium-induced release of dopamine at that concentration. Phenibut has received some attention in the bodybuilding and weightlifting communities. In some cases, that's just due to subjective enhancements when working out, but in other cases, people are taking it with the belief that it will increase growth hormone, GH, activity. There is a connection between GABA and GH, though with different effects depending on where the substance is acting. Both inhibition and enhancement of growth hormone have been reported with GABAergic drugs. For example, the benzodiazepine diazepam caused a central inhibitory effect on GH, and the same has been seen with muscimol given intravenously or with an increase in GABA levels in the brain. Yet GABA infusion into the pituitary increases GH release, and muscimol has also been shown in some studies to raise GH. Some of the studies reporting a positive effect with muscimol failed to show an effect from baclofen, whereas others have shown oral baclofen can stimulate GH secretion. Research on the effect of Phenibut on GH is not available, so extrapolation from baclofen is required. A 1998 study reported oral baclofen increased GH, but the effect was only significant in males. Phenibut was synthesized in Russia in the 1960s at Algertsin-Leningrad Pedagogical Institute, and subsequently researched for many conditions such as weakness, anxiety, depression, PTSD, and insomnia. It was introduced in its citric acid salt form in the 1960s to 1970s under the name Citrocard. In 1974, it was added to the state drug register by the USSR's Ministry of Public Health. Research around that time had shown it was similar to sedatives in some respects, but that it was less impairing and less narcotic-like in animals. Unlike other typical GABAergics, it did not possess anticonvulsive effects in strychnine, cortisol, or electroshock seizure models. Prior to 1976, its efficacy had been studied in over 1,000 patients, suffering from neurological, psychiatric, and surgical conditions. The typical dose was 250 to 500 milligrams, up to 3 times per day. It was reportedly made available to Soviet cosmonauts during a 1975 mission. Exactly how it was used is unclear, and how widely it was used in the Russian-Soviet space program is unknown. Use in Russia has continued ever since its release, but Phenibut has minimally expanded in medical settings beyond Russia's borders. However, since the 2000s to 2010s, it's become a widely used drug globally via the supplement industry, frequently being taken as a self-treatment for anxiety and stress, or as a recreational alternative to alcohol and benzodiazepines. In Australia, it's a Schedule 9 prohibited substance. It's uncontrolled in Canada and the US, and in the UK, it is not specifically controlled, but may fall under the Psychoactive Substances Act. Common doses appear to be physically safe acutely in otherwise healthy people, but the effects of chronic administration are not well understood, and even the Russian literature usually just focuses on its effects for a period of weeks, because specific effects on organ health and cognition in the long term are unknown. I'll focus on the safety aspects that we do have information on, namely overdose and dependence. Overdoses quite reliably trigger dose-dependent cognitive impairment, drowsiness, confusion, bradycardia, hypotension, hypothermia, respiratory depression, and variable levels of coma. If you use too much, it's common to fall asleep at random and to experience drunken-like impairment of motor skills. Phenibut-only overdoses are rarely lethal, but if enough is used to severely impair a person's mental status and/or if coma is present, they should be monitored in a medical setting since respiratory support is occasionally used and it's important to prevent vomit aspiration. Some of the other potential effects are mydriasis, agitation, bizarre uncontrolled behavior, hallucinations, and delusions. It's most often associated with reduced heart rate and blood pressure, but there have been reports of hypertension and tachycardia. Pinning down the expected effects of an overdose is complicated by the literature containing reports of anywhere from 5 to 10 to 15 plus grams, which may be associated with different effects. The LD50 was reported to be 900 to 1000 milligrams per kilogram in rats, and given the ED50 of 50 to 100 milligrams per kilogram for various effects in rodents, it has a relatively good safety ratio. In humans, this LD50 roughly translates to 10,000 milligrams for a 70 kilogram person, though there are clinical reports of people surviving those doses, sometimes in the context of tolerance. Typically an overdose, even one capable of producing coma, will largely resolve itself in under 24 hours, and less severe overdoses can mostly resolve in under 12 hours. Prolonged Phenibut use does cause physical dependence, leading to tolerance and to a progressively worse withdrawal period the longer it's taken or the higher the dose becomes. Rebound effects, which may essentially be withdrawal from early neuroadaptations caused by short-term use, begin within a few days of daily use for some people. This is mostly an issue when taking strong doses. Tolerance, even to light doses, will typically build within a week or two. Because of the rate of tolerance development, the Russian literature says it's indicated for a a few weeks of continuous use at the same dose. Withdrawal can include uncomfortable feelings of physical stimulation or energy, anxiety, fear, panic, depression, social withdrawal, insomnia, muscle twitches, sweating, hot flashes, irritability, and hallucinations, including, if severe, delirium-type hallucinations of objects or people that don't exist. Though it is a GABAergic and seizures should be considered a potential risk during withdrawal, it doesn't seem to be at all common for withdrawal to produce seizures. It appears gabapentinoids often alleviate most of the withdrawal symptoms. Baclofen and benzodiazepines are also at least partly effective, with the latter usually working for countering some of the insomnia and anxiety. Gabapentinoids and baclofen, which more directly replace Phenibut, are likely superior. The timeline of the withdrawal usually involves experiencing relatively minor symptoms during the first 24 hours following the last dose. From there, the symptoms increase significantly and peak from days 2 to 6. Stimulants will often aggravate the symptoms, so even caffeine is worth avoiding as a general rule. Among the combinations to avoid are dissociatives, as well as other depressants, such as opioids, alcohol, barbiturates, and benzodiazepines. The Drug Classroom is a listener-funded resource, so your support is what allows this content to exist. If you want to donate, you can do so through Patreon, PayPal, or Bitcoin. Donation details are available in the description and at thedrugclassroom.com/support. Your support is greatly appreciated.